for the seclusion and restraint debate. The pro side argument will be presented by Jennifer and Katie Silva. The con side will be presented by Deanna Payne and Katie Landry. Seclusion and restraint refer to safety procedures in which a student is isolated from others, seclusion, or physically held restraint in response to serious problem behavior that places the student or others at risk of injury or harm. For this debate, seclusion will be defined as occurring in a classroom environment with professional supervision. Both parties are able to introduce general population classroom examples in their argument. Restraint will be defined as physical or mechanical. Both parties are to avoid introducing chemical or medical restraints in their arguments. This debate will last no longer than 40 minutes and conclude with the closing argument from both sides. According to the U.S. Department of Education, the foundation of any discussion about the use of restraint and seclusion is that every effort should be made to structured environments and provide supports so that restraint and seclusion are unnecessary. As many reports documented, the use of restraint and seclusion in some cases have very serious consequences, including most tragically death. However, if restraint is needed, professionals should ensure that every precautionary step and de-escalation of the crisis has been taken. The first question in the debate will be administered to the opposing side, and the supporting side will provide their answers after the responses. Each party will be administered 3 questions that must be countered with the opposing side's response. We will now begin the debate. Question number 1. SPCE 2004 writes that restraint and seclusion can damage the trust relationship between a teacher and their client. Please elaborate on how restraint can damage the relationship between clients and faculty.
Staff relationships are negatively impacted when either restraint or seclusion are implemented. It impacts relationships being built or already established. It can break trust, and because relationships are so crucial in fostering emotional and cognitive development and mental health, it can be viewed from the perspective of a breakdown in a relationship. These methods should be avoided as much as possible. In relationships, it is important that a client knows that they can trust you because it will ensure that they are comfortable. The relationship is in more turn effective. It will ensure that goals that have been set are met.
In response to the argument, Amos states that the most beneficial interventions require a positive relationship between a technician and a client, and that restraint and seclusion has the potential to damage the trust between the two. While this may be true, what about all of the other children that could be around or other staff members? Restraining an individual when necessary should be done to protect everyone in close proximity, as well as the individual in crisis situation. It is not always possible to clear the room of all other people, so restraining a child who is causing imminent harm to themselves or others around may help the relationship with others. They need to feel safe and protected as well. Also, if a restraint is done properly and calmly, it should not have a long-term effect on the individual's emotional or developmental progression. A restraint is meant to keep an individual safe. It should never be done by someone who is visibly upset or scared. It is done with calmness and only used as a very last resort. It should not affect the individual in a negative way. It is when restraints are being overused and not properly done when emotional or cognitive development could be affected. Also, the relationship the staff has with the client prior to the restraint will help the client feel safer, especially if they trust the staff. Building a healthy relationship and pairing with the client on a daily basis will allow for a quick recovery between the staff and the client. It isn't always possible for a client to understand that the restraint is being implemented to keep them safe. However, the relationship that is built prior to the intervention will allow for the client to recover quickly from it.
According to Trader at 17, restraint and seclusion can result in physical, psychological, and social damage for children. Please elaborate on the type of psychological and social damage that can occur in children.
There are many different psychological and social consequences that can result from restraint and seclusion. Children and adolescents who had been restrained reported nightmares and avoidance responses resulting from the restraint experiences, as marked startle responses associated with being held in benign and non-threatening situations. reported painful memories and fearfulness at seeing or hearing others being restrained and a mistrust of mental health professionals. Al 1998. Increased aggression are also two other major things that can occur. Restraint due to being misunderstood can cause a person to lash out, and the cycle continues. One who is not as volatile, then the onset of depression start to be seen. These behaviors can be seen in more extreme occurrences. There is research done by the U.S. Government Accountability Office in 2009 physical and psychological injury due to the improper use of procedures, including instances of fatal injuries.
So in response to the Khan argument, unfortunately, cases in which children have been injured or have died as a result of restraint and seclusion have made the use of these methods even more controversial. So while these unfortunate events do not necessarily mean that the use of restraint or seclusion must be terminated altogether, it does highlight the need for guidelines surrounding their use. So the U.S. Department of Education published a summary in 2010 of all the statutes, regulations, and guidance in each state and U.S. territory. And this makes it much simpler for individual school and district employees to access and determine if their guidelines are strict enough when concerning restraint and seclusion. The U.S. Department of Education also published a restraint and seclusion document in 2012, highlighting 15 principles that states should follow when they're creating their laws and regulations surrounding physical restraint and seclusion. And these principles provide a guideline for states and schools as to how to further prevent physical, psychological, and social damage for children who are experiencing restraint and seclusion. According to this document, less restrictive means of intervention should be attempted to try and prevent restraint and seclusion. Restraint and seclusion should only be used when a child's behavior poses imminent danger of serious physical harm to themselves or to others, with other less restrictive interventions being ineffective. And all treatment must be consistent with a child's rights to be treated with dignity and free from abuse. Also, restraint and seclusion should not be used as punishment or be used in a way that might limit the breathing ability of a child or that might harm them. And if restraint or seclusion is used multiple times by the same person and with the same child, then those cases need to be further researched and addressed. The U.S. Department of Education also indicates there should be strategies in place to address why the unsafe behavior that's resulting in a restraint or seclusion is occurring. And anyone working with students needs to be well-versed in strategies other than restraint or seclusion, and on how to properly and safely implement restraint and seclusion if they are needed. Restraint and seclusion should be monitored as they occur to make sure that children are being kept safe. Parents should know about any policies and laws that surround these procedures, and they should be informed as soon as possible if a restraint or seclusion occurs with their child. And all policies on restraint and seclusion need to be reviewed and updated regularly. All instances of these procedures need to be appropriately documented. The documentation should include any injuries that occurred to the child or the staff involved, as well as how long the restraint took place for, or the seclusion. And the document does provide some examples and then state that when restraints are used inappropriately, these restraints are often used by poorly trained staff. So this being said, restraint and seclusion should only be used when any risk that they pose is less than that of the behavior being exhibited by the student who would be the subject of these interventions.
Okay. According to research, evidence-based practice strategies can prevent the need for restraint and seclusion and or provide safety procedures when restraint is necessary. What type of research has been conducted and what type of interventions have proven effective when the need of restraint is present?
There is a ton of research that has been done on methods that can be implemented to reduce the use of restraints. It mentioned the correct training of staff, while ensuring that staff members are supported to develop and practice. With ensuring that staff members are adequately trained, this will drastically decrease the number of incidents that occur. Cameron and Saylor came up with 6 evidence-based practice techniques that have been proven in the need for restraint and seclusion. These techniques include academic, mental health, and behavioral assessments, support for students with a focus on evidence-based practices, of life, as well as decrease students' problem behavior and improve adaptive behavior. Provided by trained professionals, use of data for ongoing decision-making, leadership of district and state level support, adaptation of practices and procedures to the needs of staff and students, 2017. All of these strategies have been proven to eliminate the need of restraint and seclusion. All of these skills build upon one another and will take time to see the effects they are having on behavior.
So in response to their argument, in a review of crisis intervention training programs for schools, the primary focus of all the programs is to provide staff members professional training on how to properly prevent and intervene in aggressive behavior. So the majority of the programs that were reviewed spend most of the training, between 25 and 50% of the training time, on prevention and de-escalation of physically aggressive behavior. And the article discusses how, as students with a large array of developmental delays are included in the general education classroom, staff do not necessarily have the appropriate knowledge needed to effectively prevent and manage student conflict and other behavior problems. So this lack of information can lead to increased escalation of student behavior that, once having the potential to cause imminent harm to themselves or others, warrants physical restraint or seclusion. And if staff have the training to attempt to de-escalate, physical restraint or seclusion may be avoidable. The 13 crisis intervention training programs reviewed all included training on monitoring restraint procedures. For example, checking that students are being restrained in the intended manner. And these programs also all trained future implementers on debriefing with students following the restraint, which further aids in limiting psychological damage to the student and allowing review of each individual situation that occurred. So all of the restraint programs included various safety procedures, such as time limits for how long the child can be restrained, and monitoring the student's emotional state. So I'm going to pull up a chart that shows all the ways in which restraint monitoring might occur, and each of the reviewed physical management packages provides guidelines and training on this piece. So. So this is the chart that shows all of the different items that would have been reviewed during the training. So that includes time limits set on the restraint if they exist, or for how long if they are in place. If you need more than one person to implement the restraint, anything that you need to do during the restraint to monitor the physical state of the student, what suggestions the package has for you, and if they're monitoring the physical distress, or if they review symptoms of physical distress when they're training you on that specific restraint package, and how to monitor the emotional state of the student while you are implementing the restraint.
Okay, at this time, the questions will now be to the pro-restraint party. Question number 4. According to Ryan, J.B., and Peterson, R.L., 2004, Public Education IDEA Act established a principle in a least restrictive environment. Describe the types of interventions that can be put in place when providing restraints in a least restrictive environment.
Children with disabilities are now being included in public school environments and often in general education rooms. Physical restraints and seclusion are being used in the typical classroom settings because of this. According to Ryan et al., restraint refers to any method used to restrict an individual's freedom of movement, physical activity, or normal access to his or her body. It is important to remember that these restraints should only be used as the last resort after all other options have been exhausted. Teachers and staff must be properly trained in order to use any of these methods, which could mean taking a CPI class, which is Crisis Prevention Intervention, or TCI, Therapeutic Crisis Intervention. Some states and districts are requiring teachers to be CPR and first aid trained because of the injuries that could be sustained during a hold. Depending on the state and district, some schools require it to be in the student's IEP or have parents consent to use restraint for a crisis situation. Restraint should only be used if a self-injurious behavior or severe aggression is being displayed. Ryan et al. States that such behaviors interfere with the student's learning, disrupts the instructional environment, and may pose threats to the safety and well-being of students and adults. The safety of the child and the children around them should come first. Removing others from a potentially dangerous environment should take place. The staff members who are placing the restraint on a child should remain calm while making sure the restraint is done properly and safely. There are different types of restraints that are taught during a CPI course or another crisis intervention course. These courses teach professionals how to transport a child who is having a severe behavior, as well as restrain them from harming themselves or others around them. The most important thing to remember about restraint is only use them as a last resort. Safety should always be #1 priority. If a staff member is not trained properly, they should not be placing a child in a restraint. I have some images of different holds that can be used for a teacher or a group of teachers or staff members who are trained in crisis intervention. These restraints can be done without harming the child and keeping everyone else in the environment safe as well. Okay, so 4 types of restraints. The first one is a therapeutic hold. This is a technique that pins the student's arms across the chest or sides while also holding the student in place. The hold should be proportionate to the student's behavior, and another teacher should be standing by to make sure they don't need any assistance. The next is a team control position. It's a more aggressive hold that should only be used when a student is at risk to himself or others. So this one uses 2 staff members. The next is a children's control position. It's another more aggressive hold that should only be used when a student is at risk to himself or others. And the last one is a 2-person escort. It's a form of physical restraint used to move an agitated student from one location to another. So if you couldn't empty the room and you needed to move the child to a more safe environment, then this one would be used.
In response to the pro argument, the most important intervention that should be in place for students who have special needs in a general education setting would be a behavior support plan, or a BSP. The BSP, according to Trader et al. 2017, should include reactive procedures, but the main focus should be on proactive measures. To be able to truly provide special education students with the least restrictive environment, we should also be supporting them in the least restrictive way. A BSP should include known triggers or antecedents of problem behavior to help teachers or other adults working in their classroom to know which times of day might be more difficult for the child to tolerate. The triggers should directly connect to antecedent strategies, which would be a framework for those adults supporting the student and to be able to prepare them or assist them through the most difficult tasks or activities in their day. Reactive procedures should be specific and efficient, but do not need to be immediately aversive. For example, if the function of the student's behavior is attention, a reactive procedure to maintain safety might be to clear the room of other children and dangerous objects. By removing what is reinforcing the behavior, attention of others, the behavior may reduce, proving further reactive steps unnecessary. If antecedent strategies are used and reactive procedures have been exhausted, resulting in a true behavioral emergency, then the use of restraint or seclusion may be necessary. If an aversive procedure does have to be implemented, it's crucial that it be done by a trained individual, as pointed out in the pro statement. The only goal of this aversive should be to keep the child and others safe. When safety is regained, the restraint or seclusion should immediately cease. A system of reentry for the child after restraint and seclusion should also be part of the BSP. This plan might include a life space interview or some other method of processing before joining peers again in the general education environment. It's crucial to have this system in place to best support the child back into their environment and to be able to learn from the situation. This might include practicing alternative behaviors for the next time that they're upset, or communicating the trigger and making a plan to regulate their emotions. Ultimately, an aversive procedure such as restraint or seclusion may need to occur, but only in only in an emergency situation and after the proactive pieces of the behavior support plan have been exhausted.
William A. Fisher, MD, conducted a review in support of restraint and seclusion. Please elaborate on his research and methods conducted in support of restraint and seclusion.
William Fisher reviewed literature from the years 1972 to 1994. According to Fisher, most of the articles he reviewed suggested that restraint only be used when there was imminent harm to either the individual or others around them. Restraint should never be used as a punishment technique and only to prevent injury during a crisis situation. The majority of programs in Fisher's review found it impossible to operate without some sort of seclusion or physical restraint. However, he also found a few articles that stated that restraint should be used to prevent destruction of property as well. Fisher discussed the importance of staff training for those who are going to be involved in restraint techniques. Being properly trained for crisis intervention will prevent further injury from occurring to both student and staff members. Some of these trainings include de-escalation techniques, which lessen the use of restraints when it isn't completely necessary. Restraints should be used as a last resort after every other technique does not prove successful. Keeping the staff and the client safe should be the focus. If the staff members are trained properly and they were using correct restraint techniques, everyone should remain unharmed.
In regards to the pro argument, William Fisher's research does also align with several points that are evidenced in articles written by Trader et al. 2017 and Amos 2004. The shared points are that only trained individuals should implement restraint and seclusion, de-escalation strategies should always be used before an aversive, and the client's safety is the top priority. Where the research differs is that both Trader et al. 2017 and Amos 2004 emphasize the need for behavior support plans focusing mainly on proactive measures. De-escalation techniques are useful once the child is engaging in the problem behavior, but the best behavior change, according to Amos 2004, is accomplished through antecedent strategies before the individual is at all agitated. By teaching regulation skills and providing positive reinforcement, the client is more likely to be able to remain in the least restrictive environment, and the relationship between the client and the provider remains positive. Training staff to efficiently use physical interventions such as restraint and seclusion are crucial for emergency situations. However, if more time was dedicated to behaviorally supporting students before they reach the point of escalation, it is likely that the need for aversive procedures would decrease altogether.
A task force approved by the Executive Council of the Association for Behavior Analysis International created a document that detailed their view on restraint and seclusion. How do these views support seclusion and restraint in the public education setting?
So the Association for Behavior Analysis International, ABAI, believes that seclusion and restraint should only be used when necessary and appropriate. So when implementing such procedures, the welfare of the client is the #1 priority. In their 2011 statement on restraint and seclusion, ABAI indicated that regulation that prohibits treatment that includes the necessary use of restraint violates individuals' rights to effective treatment. So therefore, it would be unethical, according to ABAI, to completely ban the use of restraint, as it may be necessary to keep individuals safe during their treatment. So when untrained staff use these procedures, it should not lead to hindered access to the use of restraint and seclusion by trained and responsible staff. And according to ABAI, least restrictiveness should be central in determining client treatment. So that means that a more intrusive intervention, such as restraint and seclusion, might be necessary to decrease dangerous behaviors and to lead to a better quality of life for the client. And ABAI points out that restraints and seclusion used in behavior intervention plan, or BIP, can reduce the risk of injury and facilitate learning opportunities that support appropriate behavior. So if a restraint is to be used in a BIP, ABAI states that it must be a plan that also includes reinforcement procedures. So it has to also be based on functional behavior assessment, undergo review of data, and be consistent with the scientific literature and current best practices, just like everything else in the field of ABA. So in the case of situations where an individual is engaging in behavior that poses imminent risk of harm to themselves or to others, emergency restraint may be necessary, but this should only occur when less intrusive interventions have been attempted and were unsuccessful at de-escalating the situation.
In contrast to the pro argument, while using a more restrictive intervention like a restraint or seclusion might prove to decrease the dangerous behavior quickly, the individual's emotional and physical well-being must also be considered. Implementing this type of protocol as part of a behavior intervention plan could reduce the problem behavior. However, it could also at the same time be damaging to the student. Often, clients who require the highest levels of support and the most intense interventions rely on their educators for a lot more than academic or behavior guidance. They need a relationship. This relationship is built on trust, and the use of aversive procedures can do significant damage. In fact, Amos 2004 cites first-person testimony from individuals who were physically restrained or secluded. Their reports included feelings of assault and re-traumatization from previous aversive situations where they had been victims. Ethically speaking, improving the quality of life for the client is the overall goal. Yes, for some individuals, reducing dangerous problem behavior can provide an improvement to the person's functioning. With that in mind, it's important to remember the person as a whole, and that they are much more than the behaviors they present on a daily basis. Before implementing an aversive simply because it will stop dangerous behavior, reinforcement and antecedent strategies should be used in fairness to the client's emotional health and in protecting the relationship between the individual and the educator.
At this time, the closing argument topic for both parties. The closing argument topic begins with the behavior must be based on functional behavior assessment and use data collection and analysis to evaluate progress and must adhere to the best based on research. After conducting an FBA, developing a behavior plan, why or why not should restraint and seclusion be included in a plan for an individual that may pose harm to themselves or others?
While individual states may have their own laws, approved restraint and seclusion packages used nationally are set up so that staff are only implementing safe and researched physical interventions on students. So these procedures have undergone intensive research as to how to best protect students, and this allows for minimal physical, psychological, and social damage to children who undergo restraint or seclusion. Staff training further minimizes any damage that could occur. The Association for Behavior Analysis International has set clear guidelines for when restraint and seclusion is appropriate. And these guidelines should be adhered to by all individuals who work in the field of behavior analysis and highlight how restraint and seclusion can be safely used in school environments. Overall, as long as appropriate training, oversight, and implementation takes place, restraint and seclusion should be allowed for use in public school settings.
In contrast, a behavior intervention plan should only include restraint and seclusion as an absolute last resort in a true emergency. The focus of this type of plan should be on proactive measures. As stated previously, to be able to truly provide special education students with a least restrictive environment, we need to support them in the least restrictive way. A less restrictive way to teach would include using direct instruction of replacement behaviors and the implementation of antecedent strategies. By helping the client develop strategies to regulate their emotions in upsetting situations, the individual is able to improve their ability to function socially, and the environment is a safe place to learn for all. Staff working with clients who have dangerous interfering behaviors also need training opportunities around how to support clients using de-escalation interventions. Understanding how to keep the individual and others safe without the use of aversive techniques like restraint and seclusion is essential in maintaining positive relationships between clients and educators. Relationships founded on trust can be damaged if a client experiences restraint or seclusion. When the client no longer feels safe with their staff, the effectiveness of the individual's plan could be jeopardized, and the client could experience trauma. Including restraint and seclusion as a last resort in a client's plan should be done only when the person exhibits dangerous behavior that could cause injury to themselves or others in their direct environment. Restraint and seclusion should never be used to demonstrate power over an individual or as a measure of convenience. Ethically, it's the responsibility of a behavior analyst to ensure that positive measures, including reinforcement procedures, are exhausted before implementing punishment procedures, and for many, restraint and seclusion are punishers. In conclusion, proactive strategies should be the main focus of a behavior intervention plan, with restraint and seclusion only being implemented in an emergency situation. Maintaining the positive relationships between clients and staff is easy to do when the staff focus is on teaching replacement behaviors and strategies for clients to use to regulate their emotions. By supporting clients using positive reinforcement and direct instruction, they're able to gain more functional skills, which will support them to be more independent in their everyday life.
Okay, at this time, the restriction has been concluded. Thank you for joining us tonight.